Good afternoon. I'm Dr. Sonia Dalal, consultant pulmonologist from Sterling Hospital. On the day of World Tuberculosis, we have come with a question answer session for the public and the media to know about tuberculosis and to create awareness about tuberculosis. Look, tuberculosis is not a fancy disease, right? It affects millions of people in our country. Even if you cough, like, I'm spreading millions of tubercle bacilli in the environment, and most of the people would get infected. It doesn't need a vector of malaria to come and bite you and cause the disease, nor does it need a sexual transmission like HIV/AIDS. It is a simple airborne disease which infects millions and millions of people across.
Welcome, madam, to our Facebook live page of Sterling Hospital, Vadodara. Starting with the question answers. The first question has come up is, what is tuberculosis?
By now, everyone should know what is tuberculosis because that's the most ancient contagious disease that we have. It's an airborne infection. It's an infective disease where the bacteria is Mycobacterium tuberculosis. By inhaling that, you develop disease first in the lungs and it probably affects all over the body.
And what are the incidents of TB in India?
When you look at the geographical map of India, India is basically a superpower as far as the tuberculosis goes. There are more than 2.79 million cases of tuberculosis in India, out of which 1,43,000 are suffering from drug-resistant tuberculosis, that is MDR tuberculosis. If you look at the map, more than 4,23,000 deaths have occurred in the last year only due to tuberculosis. Look, when you talk about swine flu, which caused thousands of deaths in 2016 and 17 epidemic, it made government running from places to places to take care of an influenza of H1N1. But at the same time, there were 2.1 million deaths of tuberculosis, which probably was not noted. So tuberculosis is basically a major deadly disease, and the deaths because of tuberculosis surpasses the total number of deaths because of Ebola, H1N1, smallpox, malaria, HIV and whatnot.
Thank you, madam. Can you throw some light on what are the symptoms of pulmonary TB?
Patient would start with extensive cough with phlegm, a mucoid or a mucopurulent. Patient will have a fever. Patient will complain of coughing out of blood. Sometimes the patient would come with chest pain and also breathlessness.
And how does a person get TB?
As I said, it is an airborne disease. So if I cough out, as I said previously, if I cough out like this, and if I am affected with tuberculosis, I am going to throw out millions of bacilli into the environment. And if a person who is vulnerable, let me repeat this, a vulnerable person who inhales those bacilli will have a likelihood of developing tuberculosis. If he inhales, if immunity is low, if the patient is suffering from comorbid illness like diabetes or has a cardiac dysfunction or a kidney problem or a liver problem, is more vulnerable when he inhales and develops a disease.
Madam, one of our Facebook viewer is asking that if I have TB, what can I do to prevent spreading it to other people?
He has to take care of himself by covering the mouth when he is around the people. Whenever he is coughing, he has to be restricted to his area, not cough in front of everyone. Do not spit in a local or a public place. Take the drugs regularly. If he is having a pulmonary tuberculosis and if his sputum for AFB is positive, he or she remains infected for first 2 months. So he has to take care for first 2 months not to go out in a public, in a crowded place, not to cough in front of people, and take the treatment regularly and take care of his immunity.
Is it contagious?
Yes, it is. But there is a biggest myth. The biggest myth is that a TB in the family would pass on from one to the other. So that needs to be taken care of. That myth has to be removed. It is contagious provided the person who's infected and the person who stays with the tuberculosis infected patient take care properly.
Our viewers can follow the prevention you said, and one of our viewer is asking that, ma'am, what are the tests for TB?
Again, I would like to say there is one myth that tuberculosis is always in the lungs. No, TB can affect all the body organs, and the diagnosis of TB can always be a microbiological diagnosis. If the patient is suffering from lungs, that is a sputum test. When you do a sputum test, you have to show AFB into the sputum. AFB is acid-fast bacilli. If they show acid-fast bacilli positive, the patient is infected with tuberculosis. If the patient has a lymph node in the neck, then you take a FNS, that is fine needle aspiration cytology, or you do a biopsy and document tubercle bacilli in that. Then that is the diagnostic test for tuberculosis. An X-ray, I would like to repeat this again and again on this forum, that an X-ray is never going to give you a diagnosis of tuberculosis. It can only tell that there is one lesion in the lung, or a CT scan where the lesion is in the abdomen, or an MRI where the lesion is in the brain, but it will not give a definite diagnosis of tuberculosis.
The same viewer is further asking, is BCG vaccination effective?
No. It is not at all effective, especially in a country like India where we have rampant cases of tuberculosis.
How is TB treated?
That is a fantastic question that the viewer has asked, and I would like to spend some time on this. Look, if a patient comes to me and if the patient is diagnosed with tuberculosis, and if the patient is first time diagnosed as tuberculosis, I am just going to give that patient of mine only 4 drugs, provided the culture of TB shows sensitive strain. I'm just going to give that patient 4 drugs for 6 months in a right dose, right drug, and ensure that the patient takes it regularly. It would take only 6 months for the patient to be completely cured of tuberculosis. And the cost again is not going to be much if the patient follows the doctor's orders meticulously for 6 months. It would be anywhere around 800 rupees per month.
Thank you, madam, for enlightening us. Viewer has again asked what is multi-drug resistant TB and what is extensively drug resistant TB.
Okay. So, sometime on multi-drug and then on extensive drug resistance. If the regimen of tuberculosis not given in the correct dosage, the correct dose means that the drug given according to the body weight, not given correctly, so the drugs prescribed are not correct, and if the patient is really very irregular in taking those drugs, the patient would develop drug resistance. If the patient develops resistance to 2 main drugs, that is isoniazid and rifampicin, he or she is labeled as multi-drug resistant tuberculosis. If the patient develops resistance to 4 drugs, then the patient is called extensive drug resistance. And now, due to the flaws in taking the medications let me put it very straight, the flaws from the patient side, the flaws from the implementation administrative side, or the flaws from the doctor's side, patients have now started developing resistance to most of the drugs or all the drugs, with a new eruption of the terminology, total drug resistance.
One of our viewer, Jalpa Patel, is asking, is there a better TB vaccine being developed?
That's probably into an investigative mode, but to be very honest, at the moment, no news about it.
And further, does atmosphere have any role in TB spreading?
It does. It's not the atmosphere, also the population, the crowded area. I mean, look, if you go to the slums of Baroda, I mean, if in a 400 square foot place, 10 people are staying and coughing against one another, and they have a chula and not having a good ventilation, probably they are most vulnerable to develop tuberculosis. Right? So, what I mean is good, fresh environment and a good space to live around probably is most important if you even want to stay away from tuberculosis, if you have tuberculosis, to treat it.
What are the side effects of the drugs?
Most of the drugs of tuberculosis, the primary drugs, as I said, those are the isoniazid, the rifampicin, and the pyrazinamide. These three drugs are hepatotoxic. What I mean by hepatotoxic, they have liver problems. But if the patients are being diagnosed with tuberculosis, have taking drugs meticulously, would probably not develop much of hepatotoxicity. However, the doctors have to be very cautious in monitoring the liver function test once a week in first 2 months, and then probably once in a month. And the ethambutol, the drug, which is the fourth drug that we give, has some eye problems. So a preliminary ophthalmic checkup before starting anti-tuberculosis medication is required.
What is DOTS? DOTS? Viewer is asking.
Well, when we started with a lot of problems with tuberculosis, and then the tuberculosis started becoming like a pandemic years back, and we had no clue what to do. In 1997, right, the government came up with a plan called RNTCP, that is Revised National Tuberculosis Control Plan, and where they thought that every patient needs to be followed up for tuberculosis, and they hired people to give drugs to the patients of tuberculosis and consume those drugs in front of them. So the full form of DOTS is directly observed therapy of a tuberculosis patient. Patient has to take the drugs in front of the workers of working for tuberculosis. If in a medical college, they go to the doctors, they consume in front of the doctors or the workers. In village areas, there are Anganwadi workers in front of whom they would probably consume their drugs. In the first intensive phase, they are called on alternate day basis, and then they are given a box of treatment every week and collected in empty blister packs and check whether they have consumed their drugs properly or not.
Can TB get acquired once again after getting cured and completing the dose of 6 months?
Yes, of course. Why not? As I said, we are having a burden of tuberculosis in the sense of 2.79 million people, in a lot of deaths, and MDR and XDR tuberculosis. Every time the strain might be different, right? So there is a terminology for tuberculosis, that is a relapse or a reactivation. Now, what do I mean by relapse? Relapse is if my patient is completely treated and cured of tuberculosis, he comes out with a completely different strain of Mycobacterium tuberculosis, and he gets infected with that. So he can have that, right? It's an infectious disease, so it can cause infection again and again. A reactivation, if the patient has a cavity in the lung and the patient has been labeled as completely cured, however, there are some bacilli which lies in that lung, and that if their immunity goes down, or if God forbid any other factor comes out, the patient develops diabetes or develops a renal problem or a liver problem, those bacilli probably would again sprout up and start multiplying, and that's a reactivation of the disease. So any infective disease, is there any guarantee if I have a malaria today, I will not develop malaria after 2 months? No, it is not. So that the same goes with tuberculosis. A patient once treated is never off the risk of tuberculosis.
How is TB disease treated? One of our viewers has asked.
Again, the same thing. If the patient has initial phase or primary tuberculosis, which is sensitive to the primary 4 drug, I would give 4 drugs for 2 months, followed by 2 drugs for 4 months, so a regimen of 6 months total. It's a long therapy though. Patient would start developing feeling good. They will become asymptomatic in 1 month. But all the patient need to realize one fact, that tuberculosis treatment lasts long and they have to complete it within 6 months. If not, then if they protect a drug resistance or develop a multi-drug resistant tuberculosis, it would go beyond 2 years or maybe 3 years. If they develop extensive drug resistance, it would go endless 4 years, 5 years till their AFB culture becomes negative. And I'm not sure, it's only God for the total drug resistant TB.
Any diet tips for TB patients?
Keep your immunity good, a high protein diet, right? And eat maximum, no fasting and no superstitious or orthodox things that if I do a Mangalwar, then somebody is going to come and cure my TB. Eat and keep your immunity good, but take your drugs regularly in correct doses and at correct timings. Look, I'll tell you one thing. We have seen incidences where patients are taking some of the drugs at erratic timing. Now, there are some drugs like isoniazid and rifampicin which needs to be taken on empty stomach, right? And then those things are not being conveyed to the patient. Patient is a layman. If a doctor tells the patient to take that these drugs are to be taken on an empty stomach, then you will have a good metabolism of the drug. I'm pretty sure patient is going to follow what the doctor says. So those drugs are to be taken on an empty stomach. Ethambutol can be taken post-breakfast. Pyrazinamide can be taken post-lunch. But if you give all the 4 drugs on an empty stomach, nothing like it. But rifampicin and isoniazid should always be taken on an empty stomach.
How much food is important to prevent TB and in TB patients?
As I said, the good immunity. So eat good diet and good nutritious food. No junk food would probably help the patients in controlling the disease.
Is a person with HIV infection more at a risk of developing TB?
Of course, they are immunocompromised, right? The CD4, CD8 counts are very low, right? So what is most common in our country? Which infection? Tuberculosis. So they are at a peak, they are at a very high risk of developing tuberculosis if they have protracted HIV. If they are taking their drugs regularly, right, they are supposed to take their drugs, the antiretroviral therapy as well as the tuberculosis treatment regularly.
What is prognosis of extensively drug-resistant tuberculosis?
If the patient has extensively drug-resistant tuberculosis, if the patient follows the doctor, believes in doctor and believes in himself or herself, getting tested regularly, taking the therapy and believing that the therapy would probably last for a long time, maybe 2 years, maybe 3 years, and again, thousands of dollars or thousands of rupees that the patient has to spend from the pocket. If the patient has it can be curable. I have my patients who had extensively drug-resistant tuberculosis, but I was honestly successful in convincing them to take the drugs in spite of them developing a lot of toxicities, sitting with them, counseling them. Look, you probably would have a hearing problem with an aminoglycoside, with an injection. You would have a problem. You will need a continuous monitoring of your liver functions, a continuous monitoring of your kidney functions. Your legs would get sore. You would develop a lot of neuropathies, but those things are not going to kill you. Please bear with us. Please bear with me. Both of us are going to win over the tuberculosis. And I can give you examples of patients that they have probably now been completely cured of their exterior tuberculosis.
Why rifampicin and isoniazid taken empty stomach?
Oh, that is what it is indicated. Their metabolism is fantastic when it is taken on an empty stomach. The action that is how the pharmacokinetics means it is the pharmacy of the drug which tells that absorption is fantastic when it is on the empty stomach.
Who is at risk of drug resistance TB?
4 things. Number 1, if the drugs are not taken in the correct doses. Number 2, if incorrect regimen is given. Number 3, if the patient does not take it correctly and the patient takes the regimen very lightly, so he takes on Mondays and Tuesdays and does not take on Wednesdays and Thursdays. So those are the times that the patient are likely to develop drug resistance. Second thing is very important that I would like to say in this era, if I get a patient or if any of the consultant or a physician gets a patient, don't think that the patient has come to you for the first time and has developed a sputum AFB tuberculosis and he is the primary or initial, tuberculosis. Just get a AFB culture done. When you get an AFB culture done, always have the courage to get the sensitivity and tell the patient, look, you are having a sensitive strain, right? And you'll be treated if you take it for 6 months. But if that patient who comes to you for the first time and has at least 2 or 3 drug resistance, then he's not a simple case. He is multi-drug resistant. So investigation along with the treatment is the key to win over tuberculosis.
Any lifestyle tips to avoid TB infection?
A tip to avoid:
Lifestyle tip.
stop staying in India. Go away from India, because India is full of TB. Look, every second a person in India dies because of tuberculosis. Not that I'm a proud Indian. Let me tell you this. I'm a really proud Indian. But we all have to join and win over tuberculosis. Right? We have to. Those are the tips. That don't cough in front of everyone. Like, if Maharashtra can have Amitabh Bachchan as an ambassador for tuberculosis, let us have a good guy who is very influential as an ambassador for tuberculosis, right? And fight against that, right? Let our Prime Minister Modi realize, right, that this is not the time for a bullet train, and no time for getting fancy things to our country. It's a time to fight against a simple, communicable or a contagious disease. Let us all join hands together. Don't cough in front of everyone. Have a good immunity. No fasting, right? Please leave gods for doctors to treat the tuberculosis, right? Once you are treated, yes, God is always with you, but believe in your doctor, what the doctor says, right? Those are the tips that I would suggest to the patient, because many a times patient says, "Madam, मैं अंडा खाऊंगा, मेरे को ठीक हो जाएगा, मैं टीबी की दवाई क्यों खाऊं?" It is not like that, right? मैडम, मेरी माता जी ने मुझे वरदान दिया है, मुझे तो कोई इन्फेक्शन नहीं होगा. When you will die, माता जी is not going to come. It's the doctor who is going to come to by your side.
Right? One of our viewer is asking, why is the most common anti-tuberculosis drug rifampicin now becoming most resistant drug? What is the alternate treatment for such patients?
Wrong dosage, right? And wrong timing. These things needs to be remembered. Best metabolism of rifampicin is on empty stomach. I have seen many doctors giving rifampicin post meals, giving rifampicin at night. And then we have something called fixed drugs combination. And that probably was designed by a pharma company or even the government for different weight category of patients. But then those drugs are to be given together on empty stomach. What they do is they give fixed drugs combination in a divided 3 doses or a divided 2 doses, which is a crime, which is a disaster, which should not be done. So if the patient is given a patient's weight is 50 kgs and he needs a rifampicin in 450 milligrams, what they do is they give 225 in the morning and 225 in the evening, which is brutal for the patient. Patient doesn't know. Patient is saying, "Saab ji, mujhe to ye bola gaya tha, subah mein ek lena hai, raat ko ek lena hai, khatam." The patient doesn't know anything. Correct knowledge of pharmacokinetics of the drug, correct knowledge of what timings and correct knowledge of the dosage is very, very important when you treat the patient of tuberculosis. And friends, I would like to tell this. It's we are responsible for the petty scenario that we have today for tuberculosis in our country. It's a rampant case, 143,000 MDR tuberculosis that we are seeing in our country. It's a real bad scenario.
Does smoking increase chance of catching TB infection?
Smoking increases chance of everything. Right? It increases chance for lung cancer, it increases chance for cardiovascular disease, it lowers down your immunity, right? So the statutory warning should be, it is not carcinogenic, it can cause any infection. Stay away, refrain from smoking, refrain from alcohol.
One of our viewers is asking, ma'am, is TB uncommon in hilly areas? In other words, does it depend on your geography and atmosphere?
If I'm coughing a lot and if I'm transferred to Nainital and if I start coughing, am I going to be cured because of atmosphere? No, right? Okay, because we get a lot of patients in Baroda who have come from UP, MP, Rajasthan, suffering from MDR, XDR tuberculosis, right? People staying in Mount Abu are coming over here and getting treated, going back to Mount Abu. They would infect the patient. So there is nothing that a hilly terrain or somewhere where there is a nice atmosphere, a patient is going to be treated or will not have tuberculosis.
To start a tablet bedaquiline, after how much risk of how have suffering of extensively drug resistant tuberculosis?
Look, bedaquiline is a drug which is probably made by multinational companies. It is only given to the Indian government. It's not still available into the private market. The patient diagnosed as extensive drug resistant tuberculosis has to be enrolled as XDR tuberculosis or a TDR tuberculosis, that is totally drug resistant, and to be enrolled in the subjective government institution, and then the bedaquiline is given. It is given one every day for 6 months.
What should the community or society do to help WHO and national scheme Stop TB, a successful one?
We all have to be aware. Awareness, awareness and awareness, right? If even this today's talk is going to have some impact on the people, if they are probably coughing for more than 15 days and that they realize that they need to be screened for tuberculosis, I'm sorted today, right? So it has to be effort from every side. We all have to, if I have someone that I know that this patient has MDR tuberculosis or XDR tuberculosis, I start notifying the government. Most important thing is start notifying the government. Get together, join hands together. Doctors, patients, the government staff, the politicians, the actors, everyone joins and win over tuberculosis. That is most important that I want to say today.
How can multi-resistance drug tuberculosis be prevented?
This question is coming again and again, so I am very happy that the awareness is prevailing. It's coming in different ways. As I said, please, whenever any patient who is suffering from tuberculosis, whenever you go to your doctor, ask only few things. Is my tuberculosis a sputum AFB culture positive? Please, I want to get an AFB culture done and I also want to get a sensitivity done. Is my tuberculosis sensitive to the primary drugs? Am I given the drugs in right timing? And am I given the drugs in correct dosages? If you know only these 5 things, you are sorted in 6 months taking the tuberculosis regimen perfectly.
How important is early diagnosis in case of TB?
Tuberculosis?
Yes.
The earlier the better, so that you are not spreading your infection in the community. If anyone has a cough, a weight loss, which is fever, which is there for more than 15 to 16 days, especially in a country like India or a developing country, should immediately go and screen for tuberculosis, right? Immediately get checked, get a sputum test done. If the patient has a lymph node, get a FNSC or a biopsy done. If the patient has got abdominal problems and the doctor is suspecting, get a colonoscopy done or get a biopsy done. Immediately diagnose early, treat early, get cured early.
Why nowadays there are increasing cases of extensive drug resistance tuberculosis?
Flaws from patient, flaws from doctors, flaws from the policies. Okay, patient is irregular. They become very casual at the end of 1 month when their symptoms completely go away. So then they think, I am cured. Why do I need to take a long-term treatment for 6 months? Floss from doctor, irregular doses. If to a 60 kg patient, I give a drug regimen of 40 kg, is not going to work. The patient is going to develop drug resistance. If the patient needs a primary 4 drugs, isoniazid, rifampicin, pyrazinamide, ethambutol, I am very well adding one more drug in form of an antibiotic, giving a quinolone like levoflox, which is a good second-line anti-tuberculosis medication. Still, we very well give it to the patient, right? And wrong regimen. And major important thing is the flaws from the government and the flaws from the policy. If a patient from Rajasthan comes to me, and if I diagnose that patient as MDR, tuberculosis patient does not have enough money in their pocket, I send that patient to the government hospital in Baroda. The doctor would say, no, ये तो हमारे एरिया का नहीं है, इसका एरिया तो राजस्थान लगता है, उसका राशन कार्ड राजस्थान का होगा, he has to go back to Rajasthan. He goes back to Rajasthan. अरे तुम्हारा डायग्नोसिस तो बड़ौदा में हुआ था, you go back to Baroda. That poor guy gets tired at the end of the day running and shuttling between Rajasthan and Baroda. So it is our collective duty to guide that patient that, look, you have an MDR tuberculosis, boss. This is what my diagnosis is. I'm sending you to the government. The government would now take your card out. This is your regimen. And then that regimen is being transferred to that, DTO or DTC, whatever they say, where the patient is diagnosed with tuberculosis. And the treatment is completed.
What about routine use of quinolones?
That is a fantastic question which has been asked, and it has made my day. Most important thing is, every one of us are using quinolone like chana mamra and bhelpuri. Okay? Quinolone, levoflox, even if I sneeze, I am given a quinolone. Even if I cough, I am given a quinolone. A patient goes to a general practitioner, has a diarrhea, has been given a quinolone. A quinolone is a drug which is to be preserved as a second-line tuberculosis medication. It is not to be used as a right, left and center, right? Okay, as an antibiotic. Right? There are so many good antibiotics which can cure your diseases. Spare quinolones, please. Even in a pneumonia, the first line of treatment is quinolone. No, in the country like India, in a developing country like India, when tuberculosis is very rampant, please preserve a fantastic molecule like quinolone, which can be used in MDR or in XDR tuberculosis.
Continuing, addition to that, one of our viewer is asking, is this drug producing extensively drug resistance tuberculosis?
If used in a wrong way, yes, it does. If it has been used like a chana mamra, or if it is used like, cheek khaya to levoflox le lo, or if it is an OTC drug given by a pharmacist without a prescription of a doctor, yes, it can. It can cause.
Is the government's DOT program successful or a failure? What do you advise the government to make new program for curbing tuberculosis?
Ma'am, I would have been in government by this time. You can understand it's a frustration which is all bringing us into a private practice and going away from that the government program, how to make it successful. To be very honest, it's not the government's fault. They are doing fantastic job, but it is the fault of the policies, the policy makers, and the flaws at a lot of levels, which is making these dots not that successful though they are trying to formulate different designs and different programs to make it successful.
Is there any heart disease risk during tuberculosis?
There are a lot of risks. I mean, you have because the tuberculosis is not controlled or cured properly, there are a lot of risks. The patient develops a respiratory failure, patient develops a pulmonary hypertension, patient develops cardiac problems because of the load on the lungs and eventually to the heart.
One of your viewers is asking, can a patient at a high risk of acquiring tuberculosis after getting treated for pneumonia?
Yes, of course. Your immunity is low, as I said. When the immunity is low, if you don't eat properly, you are most vulnerable for infection of tuberculosis.
A patient with known case of bronchial asthma, if develops tuberculosis, what extra precautions has to be taken?
Take your drug regularly and control your asthma. There is nothing that you have to do something differently for an asthma patient. An asthma patient needs to be treated the same way like a tuberculosis patient. At this point, I would like to put two things: tuberculosis in pregnancy and tuberculosis in a lactating mother. If a pregnant lady is tuberculosis, has protracted tuberculosis, there is no harm in taking anti-tuberculosis medication, and the fetus in utero is not going to have any side effects, provided the patient has got simple tuberculosis taking 4 drugs, right? I'm not talking about multi-drug resistance or extensive drug resistance. I'm just talking about a simple tuberculosis. A pregnant lady can very well take 4 drugs when she's pregnant. Similarly, if the patient after the delivery develops tuberculosis, can also feed the child taking anti-tuberculosis medications and has no side effects.
Does tuberculosis regime affect other system of body? Any adverse effect of that?
There are a lot of side effects and which needs to be monitored. As I said previously, it is hepatotoxic. Hepatotoxic means there are side effects on the liver. Liver function needs to be monitored every week in the first 2 months and then once in a month till the drugs are on. If the patient is on injectables like aminoglycosides, that is streptomycin, kanamycin, amikacin, you need to monitor 2 things: the kidney functions as well as their hearing thing. They can develop hearing toxicity, or they can sometimes become have a hearing problem and can become deaf. If the patient is on ethambutol, patient can have ophthalmic problems. If the patients are on drugs like isoniazid, linezolid, which is a second line, they can develop a neuropathy, that is tingling and numbness in the leg.
What are the causes of respiratory disease?
What respiratory disease? That is a very huge and broad question the viewer has asked, right? There is a huge cocktail of respiratory disease. So which respiratory disease they want to know? Asthma is either a hereditary disease, allergic and non-allergic asthma. COPD, most of the causes are smoking and pollution. Tuberculosis is an infective disease. Pneumonia is an infection which can be protected from the community. Lung cancer, again, no reason, or smoking can be one of the reasons. Then we have interstitial lung disease, again a broad thing. Interstitial lung disease can be idiopathic, can be because of drugs, can be because of other connective tissue diseases, other causes. So these are broadly types of respiratory disease that we see in and day out, and those are the, the viewer who has asked the question should probably pinpoint and ask which disease that he or she wants to know.
I would request the viewer to ask a specific question, which respiratory disease he wants to know about.
Exactly, yeah.
Further, a question has asked that what are the common myths of TB and what are the facts to that?
Common myths is, number 1, when I say I have TB, it's only in the lung. No. Okay? No. Tuberculosis can occur anywhere. It can occur in the brain, it can occur in the eye, it can occur in the nose, it can occur on the lymph nodes, kidneys, liver, everywhere. So the myth is yes, it's only because it's very dangerous when you have pulmonary tuberculosis because it is contagious. The patient is infected, but tuberculosis can occur anywhere, right? The other myth is that tuberculosis would not occur in a healthy or a wealthy people. It's a poor man's disease. Look, if I have a driver, I'm going in a Mercedes and my driver is suffering from tuberculosis, and if he coughs and if my immunity is low, I'm going to, be suffering from tuberculosis. So tuberculosis has no boundaries, right? It is an airborne disease. It can affect anyone. So these are the myths that we need to, and tuberculosis is it's a friendly disease, very important, remember, right? But if I stop taking my treatment at the end of 1 month, it is going to be the biggest enemy of your life.
Are there some rapid tests to diagnose tuberculosis and drug resistance?
Of course, there are some genotypic tests which are now available in the market, right? So, most important thing, as I said first, there is no radiological diagnosis of tuberculosis. An X-ray, if a radiologist writes that X-ray suggestive of tuberculosis, is absolutely wrong. The radiologist should always tell that these are the lesions in this part of the area, please do a clinical correlation. My microbiologist friend would give me a correct diagnosis of tuberculosis. When I give a sputum or when I ask my patient to give a sputum, my microbiologist friend would say, hey Sonia, your patient is having AFB positive. Or then I said, okay, look, my patient is AFB positive. I want to know, this is within just 2 to 3 hours, my patient is going to, my friend is going to tell me he or she is positive. I'll say, okay, then I want to know what about the drugs that I need to start in my patient. I'm not going to wait for 21 days till you go raw culture and tell me. My friend would come and tell, we have fantastic tests now. There are genotypic tests, which is called Gene Expert, or an LPA, that is line probe assay test, which would give us a resistance pattern of 2 primary drugs of tuberculosis, that is isoniazid and rifampicin. If a patient undergoes a Gene Expert test, immediately the microbiologist would come and tell me the patient has got rifampicin resistance and rifampicin sensitive before the next sunrise. Right? So within 24 hours, I will come to know whether my patient is sensitive or multi-drug resistant.
What is the value of serodiagnosis test for diagnosis of tuberculosis?
No value. Please, this is very important and this message should go to all the viewers and everyone saying today, there is no value of TB IgG IgM. There is no value of TB quantiferon gold in the diagnosis of tuberculosis, especially in a country like India when tuberculosis is rampant.
What is prophylaxis of tuberculosis?
In India, no prophylaxis.
If patient has diabetes and tuberculosis together, is it must that patient is on insulin, or if the sugar is in control on tablets, then is it okay to discontinue insulin?
Ideally, if the patient has got diabetes and tuberculosis, the first 2 months the patient should be well controlled of sugars, right? Because infection and sugar are like a vicious circle. First 2 months ideally should be on insulin. If the patient's sugars are controlled, then it can be switched over at the end of 2 months or in intensive phase to oral hypoglycemic drugs if the sugars remain below 200.
One of our pregnant viewer is asking, what should I do if I'm pregnant and I have TB?
So take your drugs regularly. Your fetus is going to be healthy. Don't worry, there is nothing to worry about it. Take all the 4 drugs. It is not going to have a contraindicative effect on your fetus.
Our viewers would like to know your personal experiences with patients suffering from tuberculosis.
My personal experience is, honestly, if the patient comes to me, I'll be, after their life to get a complete cure of tuberculosis. Even if the patient comes to me for the first time, I would still get a culture done to see that the patient is sensitive and treat that patient meticulously for 6 months. And if the patient is MDR or XDR, it's going to be a follow-up from my side rather than the patient's follow-up. And I would be very strict with them to complete the regime at the end of 2 years, 3 years, or no matter how long it takes.
Any specific case you want to share with our viewers which you remember?
Alright, so I had a patient who was from Ahmedabad, who came from Ahmedabad. The parents were staying in Vadodara, and she got an XDR tuberculosis, and she was then abandoned by her husband because he found out that she had tuberculosis. And when she came to me, she was completely shattered. She needed psychological support. She needed, and she did not have much of money because she was completely dependent on the brother. But yes, the brother, the father were very supportive, and they did whatever I said. And she took treatment for 3 to 4 years. She had a lot of toxicities in terms of neuropathy. She had a lot of problems. I had to send her to an orthotist to get a special boot done for her for walking. She had some ototoxicity, she could not hear properly, but yes, she did complete the treatment at the end of 4 years, and now she is moving well, and she's probably, I heard that, married again. So that is one of the biggest victory that I had, that convincing a patient to take a long-term regimen, following up the doctor meticulously, getting investigated properly, right, and living life to fullest. One more case I would like to elicit: a newly wedded girl brought by the husband after 3 months of marriage, coming out to be tuberculosis positive. She took drug for 3 months and probably went to her, mica, and stopped taking for 15. She didn't take for 15 days. She came back to me again, came out to be positive. Turned out to be XDR tuberculosis. Husband was really, really very supportive. Brought her every time for AFP tests, got a culture done, got a CT scan done. We took opinion from Bombay and everything. She took it for 4 years. She's now fine and now pregnant. So that is most important thing. If the patient thinks that we can do it, and if the doctor gives a good support and good psychological support, together we win over tuberculosis. And that is what I need. And that is what my appeal is today on World Tuberculosis Day. It is not a single effort, it's a conjoint effort. So let us all join hands together to win over tuberculosis. Right? Let us have a good policy. And I would urge our leaders who are there, the political leaders, to have a good system so that we win over tuberculosis. Let us, the bullet train or the other policies probably are a distant dream, but this is what we need to achieve today itself.
Fabulous examples you gave, ma'am, and this proves that doctors are next to God to save people's life. One of our viewer has asked that how latent tuberculosis infection be diagnosed and treated.
And why do you want to diagnose a latent infection? 40% of Indian population is suffering from tuberculosis, whether it is latent or whether it is infective. So 40% of the patients are, keep your immunity good, eat well, right? If you're coughing continuously for more than 15 days, get yourself investigated thoroughly. Tuberculosis infection need not be treated. It is the disease which need to be treated. We are different from the Western world. Right? In Western world, they are very, very meticulous about diagnosing the tuberculosis infection and giving a prophylaxis, as you asked me in the previous question. But in the country where tuberculosis is rampant, every minute a person dying of tuberculosis, more than 2.4 million cases of tuberculosis over here. We are not worried about the latent cases. We are more worried about the resistance pattern which is coming up in our country. Yes, latent TB is again very important, but then only thing is that patient, if immunity is good, following up is good, investigations are perfect, I'm pretty sure we can win over that as well.
Does community-acquired multi-drug resistance and extensive drug resistance tuberculosis exist?
There is no yes, of course, it does. It does. The thing is, if my patient is MDR or XDR tuberculosis, and if my patient goes in a community, let's take it goes in a marriage, and he coughs out. No one knows. I mean, if you go in a marriage, you tell me, and you are sitting with a guy who is suffering from XDR tuberculosis, and if you protract tuberculosis, you are not going to be sensitive to the primary 4 drugs. Your strain is again going to be MDR or XDR. Right? So, you have to keep your eyes open. That's precisely what I'm trying to tell you. If a patient walks to me in OPD and he says, "Mere ko to first time TB hua hai," still, I will get a culture done of that patient, and I will also get a sensitivity done of that patient, just to see that patient is a sensitive patient, or a patient has got a resistance pattern.
How sensitive tuberculosis patient will convert into extensive drug resistance tuberculosis?
I'm very happy that the awareness about resistance is coming up. Honestly, I'm very, very happy, right? But it has to be our effort. Again and again, I'm repeating on this forum. Number 1, wrong doses for wrong weights, wrong timings, giving a fixed drug combination as a twice a day or a thrice a day regimen, and a wrong regimen. including a quinolone in the first line drug, is absolutely wrong. At the end of 1 month, if the patient is coming out to be sputum AFP positive, all the doctors are very well jolly adding a quinolone or adding an amico glycoside in the form of streptomycin. That is absolutely wrong, right? And most important thing is, patient starts feeling good at the end of 1 month, they become irregularly irregular, defaulters, which we call. So defaulting from the regime, right, is again the reason for MDR and XDR tuberculosis. So if the patient comes out to be diagnosed as tuberculosis, please sit with them for 5-10 minutes and tell them, look, you will be fine at the end of 1 month. You will feel absolutely on the top of the world at the end of 2 months. But finish 6 months. You have to take your regimen for 6 months. If you make tuberculosis your friend, finish your regimen for 6 months. Tuberculosis is the only disease in the world which is completely curable. But if you play with it, you foul with it, it is going to be your deadly enemy.
Well, ma'am, we have got 6 thumbs up from 6 viewers, namely Mayuri Vaidya, Jyoti Patankar, Madhuri Kulkarni, Dr. Ashish Patel, Nandini Gaur, and Jalpa Patel.
Thank you so much. I appreciate it.
One more question. Is there any role of alternative medicine in treating tuberculosis?
No. Big no.
And viewer Kalyan Hospital has complimented that good informative talk.
Fantastic. Thank you so much. I'm indebted.
One more question. Follow-up advice to open case of tuberculosis.
Follow-up advice to open case. Okay, so I have been speaking this again and again, right? Please go to your doctor, visit regularly, get yourself investigated thoroughly, follow the regimen which the doctor is giving you, eat well, good nutritious food, get your tests regularly as advised by doctor. Don't argue with your doctor that you're a very expensive doctor, right? And follow up after completing the treatment also regularly with your doctor and believing in what your doctor says.
Madam, any message you want to give to our society in this forum?
Let us all join hands together to win over this deadly disease which is called tuberculosis. Let us all win. And even if one person that you think in your family or around in friends coughing for more than 15 days or 20 days with fever, please send them for screening for tuberculosis. Diagnosing early, treating early, together we can. Thank you so much.
Any comments on isolation in family?
No isolation. Or that is something which is a big myth that a tuberculosis patient needs to be isolated. If you take a proper care of a patient, I don't see, because that patient would probably be down because of the disease and also psychologically down, that I have been left around. No, nothing. Just see to it that the patient is around 6 feet little distant and the patient does not go in a crowded area. That's it. But there is no isolation. Isolation was only in the 1960s and 50s when we did not have a good drug regimen for tuberculosis.
One more question. What kind of precautions are needed to be taken by the person who are treating TB patients? She wants to ask medical professionals who are treating TB patients.
Okay, fine. So I treat every day. I see ample of patients, right? So just little thing is wear a mask when you know that the patient is suffering from tuberculosis. Not a simple mask, not a handkerchief. Wear N95 mask. Always auscultate the patient from back, right? And once the patient goes out of the room, right, clean your hands and all the place where the patient has coughed with either a sterilium or a simple spirit that you have, and please examine those patients into an aerated room.
What is the screening pattern of government to identify tuberculosis patients? Is the current method successful? If not, what new initiatives can be taken?
There are a lot of initiatives which have been taken. I mean, the government has now already started. They used to treat only giving dots only to a primary patients. Now they have regimen for MDR patients. They have regimen for XDR patients. And it's the government's initiative now for a bidaquilin for total drug resistance. So the government has already started doing it. The screening initially was sputum AFB for 3 days, right? They do it, and then they would categorize into category 1, 2, 3, and 4 initially. Category 1 was sputum AFB positive, and they used to give intensive phase for 2 months, 4 drugs, and followed by 2 drugs of continuation phase. Category 2 was a relapse or reactivation. Category 3 was sputum AFB negative, right? And category 4 was drug resistant tuberculosis. Now they have categorized those category 4 into MDR, XDR, and TDR, and they are doing extensive work to combat and fight against tuberculosis. And they are doing also a lot of tests which are free, AFB culture as well as the genotyping tests.
Ending this live session today, I would like to thank Dr. Sonia Dalal for such an informative talk.
My pleasure. Pleasure is all mine.
Thank you all viewers to watch us and be patient.